Hello, everyone, and welcome to today's session on interoperability and 21st century cures. Who can you trust? My name is Lee Barrett. I'm Executive Director and CEO for ENAC, the Electronic Healthcare Network Accreditation Commission, and I'll be moderating today's webinar. We'd like to make today's session as interactive as possible and get many of your questions as well addressed. So before we get started, let me run through a few items so everyone knows how you can participate. First of all, as far as participation, you'll all have the opportunity to submit your questions either to myself or to the panelists by clicking the questions pane on you see the panel, the GoToMeeting control panel on the right of your screen. You can submit your questions at any time throughout the entire presentation, and we will get to them when we finish. We're looking to probably go for about an hour and 15 minutes of content, and that'll leave us with about 10 to 15 minutes for Q&A at the end of the session. And if we run out of time and we have a number of questions, we will reach out to you to address any unanswered questions during our post-session follow-up. Additionally, each of you will receive a follow-up email tomorrow with a link to view today's session, the recording of the session, which will include both the video and the audio, so that if you want to, again, forward it on to somebody else who in your organization didn't get a chance to participate or listen in, at least you'll be able to have both the video and the audio components of the webinar. So you will be getting that tomorrow in the link. So let's get started. As part of the 21st Century Cures, interoperability of healthcare data exchange and the Trusted Exchange Framework and Common Agreement, TEFCA, our clinical data will be moving through this new digital highway at hyperspeed. The Office of the National Coordinator, and I'm going to refer to it as ONC going forward, and 21st Century Cures Act, TEFCA, the Information Blocking Rule, the Fire at Scale Task Force, FAST, are all, and basically I'm not even going through all of them, both John Rancourt and Chris Muir of ONC will be going through those in more detail. But the point is that all these initiatives are promoting interoperability and continuing to assist the industry with the implementation and achieving our industry interoperability goals as an ecosystem. And as a result, providers, health systems, vendors, health plans, other healthcare stakeholders are going to see, related privacy and security implications as we increase the number of the connection points to provide and enable interoperability architecture for the greater access of data and provide better patient access, as well as we're trying to kind of promote as well patients having more control over their data. Today, our panelists of data exchange experts are going to discuss the sweeping healthcare industry changes, the implementation challenges that we're facing for the industry, and the impact of stakeholder organizations as patients, consumers begin to experience secure, efficient, and authorized access to data in an interoperable manner. We go to our agenda. So our agenda today, we're going to go through introductions, which we're doing. I'm going to provide kind of an overview of the interoperability landscape. Then we're going to hear from ONC on the interoperability update that they'll be providing. The CARIN Alliance will be going over the code of conduct. I'll give you talk to you basically informationally about some of the programs that ENAC is providing, and then Coral is going to talk about their involvement as an interoperability influencer. Then we'll get into the QA portion of this. So let me introduce to you the panelists. First is Cliff Baker, who is CEO and co-founder of Coral. And Cliff is an industry leader in information technology, privacy and security. He's got over 25 years of industry experience. In his dedication to the industry and passion to tackle many of its most challenging risks, Cliff has created solutions that are leveraged and used by organizations across the nation. He's founder and CEO of 2 successful companies that provide risk management services to organizations, including many of the nation's leading healthcare organizations. He's also led the creation of the HITRUST framework, which is one of the most broadly adopted healthcare security and privacy frameworks in the industry. And he started his career with PricewaterhouseCoopers. Along with myself, he and I are both alum of PricewaterhouseCoopers, where he established and led the firm's first dedicated healthcare security practice. He does a lot of speaking and is a published author on information security, compliance, and risk management topics. Next is Ryan Howells, who's a principal at Levitt Partners. The company is based out of the Washington, D.C. office. Ryan has worked with the White House, Congress, Health and Human Services, VHA on healthcare policy and interoperability issues. He currently leads the Caron Alliance, which is a multi-sector public-private alliance focused on giving consumers digital access to their health information. He is a member of the CMS Medicaid Information Technology and Architecture Governance Board and the Care Quality Steering Committee, ONC's FAST Identity Tiger Team, the Technology Association of Georgia's Digital Health Board, and COVID-19 Healthcare Coalition. He also serves as a board observer for multiple healthcare companies. He received his master's in health administration from the University of Southern Cal, where he was also a Dean's Merit Scholar. He holds a bachelor's degree in English from Brigham and is a project manager, PMP. He and his wife, Allison, and their children live in Atlanta. Great to have Ryan with us as well. Next is Chris Muir, who is Director of Standards Division at ONC. Chris joined ONC in January 2007. He has worked in state and federal government for over 25 years. He's currently works within ONC's Office of Technology as the Standards Division Director. Prior to his position, he was Director for the State Health Information Exchange Cooperative Agreement Program, in which ONC awarded over $500 million in grants to enable health information exchange in each state. Previous to ONC, he was Strategic Project Manager for the state of Arizona, CIO's office. He led information technology initiatives, including Arizona's HIT program. He also received his undergrad in poli-sci and master's in public administration from Arizona State University. And next is John Rancourt. John is Director of the Interoperability Division, Office of Policy for ONC. He is involved with all of their interoperability initiatives at ONC. He's been involved with the Trusted Exchange Framework and Common Agreement, TEFCA, strengthening the technical advancement and readiness of public health via Health Information Exchange Program, the STAR HIE program, public health, including opioid emergency, state and Medicaid interoperability efforts, value-based transformation enabled by Health IT, consumer engagement and data access, and engagement with behavioral health, EMS, and long-term post-acute care providers. And during his career in health policy, John's worked in Capitol Hill as a patient advocate and as a journalist. So you can see we have a stellar set of panelists here really talking about the key issues that are going on in interoperability. And I think that you'll find the session very interesting and hopefully engaging as well to all of you. So let's start. Let me give you a brief overview of ENAC, again, the Electronic Healthcare Network Accreditation Commission. We were formed in '95 as a nationally recognized and 501c6 nonprofit entity. We're also federally recognized as a standards development organization. So we've been focused over these past 25 years on developing a number of accreditation programs. And we're also certified by the Drug Enforcement Agency for e-prescribing for controlled substances. Our accreditation programs and the process are very transparent and are available to all of you to be able to download, take a look at. We incorporate privacy and security, technical, as well as stakeholder-specific business requirements. You can see over on the right are over our various accreditation programs that we have. We also, as far as our privacy and security, we work with a number of organizations as far as addressing their third-party assurance requirements. And we've got a commission that comprises all of our various programs and stakeholders that we have as part of ENAC's governing process. So with that, let me turn it to Cliff. Do you want to give an overview on Coral?
Yeah, thank you, Lee. Just a couple of quick words here. So Coral's a healthcare privacy and security firm. We started in 2012. We work with health plans and health providers across the country. We worked with hundreds of organizations over the years to essentially help those organizations integrate. So there's a little bit of an echo. Hopefully that's not too distracting for everybody, but essentially help our clients integrate tech vendors and service providers into their environment so they can access sensitive data to provide key services to our clients. And so over the years, we've worked with probably 20,000 plus different technology and service providers to get them integrated and plugged into our clients' environments. And in today's presentation is really from a practitioner and covered entity perspective, really what are some of the key considerations to walk through as you start building these interface architectures.
Great, thank you, Cliff. So let me take a couple of minutes to provide kind of an overview and kind of set the tone for our panelists and really talk through kind of the current kind of healthcare landscape, what we're doing as far as interoperability. And I will not be stealing John and Chris's thunder from ONC, but I want to at least set context for you as we get into and we start talking through it. So the ONC factor, and again, I think the key here is the importance and how critical ONC has been in helping to drive and set kind of the overall architecture roadmap for interoperability as we're moving forward there. And I think you're going to hear a lot more detail from John and Chris as they go into some of the rules, what's happening, but it's very exciting. And I think for all of us who are involved in it, it's very exciting to see the work, the effort that is happening in the industry. If you look at their framework here, I mean, there are several goals that they have outlined that they're focusing on as far as interoperability, including promoting health and wellness, enhancing the delivery and experience of care, building a secure data-driven ecosystem to accelerate research and innovation, major focus, and you're going to hear them talking about that from the standpoint of public health and at federal level as well. And then, connecting the healthcare and health data through an interoperable HIT infrastructure and how to do that. I mean, there's a lot of moving parts with this framework that are in play today, and you're going to hear from them about what all of those are and where they are in the process today. There are some crucial goals as well that we're, ONC has been focusing on, and I think that we're all gotten behind. One is certainly that individuals are at the center of all of this, and providers have a seamless ability to securely access and use the information from a variety of different sources. One of the, I think, key premise that has come out of all of this is really the access to individuals' health information and providing individuals to have a lot more control over what and who has access to their information, and to create that longitudinal healthcare record for individuals as well from all the various sources that are out there. And then also assisting public health agencies and researchers, and that has become even more critical, obviously, as we've gotten into COVID and the ability to have that information to be able to share not only at a state, but certainly at a federal level. And so the key comes down to not only cutting edge treatments, but things like, the vaccines and all the work that's going on here. The sharing of data has been absolutely critical. From the health principle perspective, there are several that they're also been focused on. Certainly value, putting individuals first, building a culture of secure access. So the whole aspect here and importance around privacy and security of how this data is exchanged is critical. The research side of this, the innovation and competition, and I would tell you one of the things I can tell you that I felt very good about what ONC and the industry has been doing together is really working very closely together, sharing a lot of information, and working. I think the partnership with ONC at the federal and with the private sector has really been very important. And then the whole aspect, I think, on stewardship, as ONC has tried to and has promulgate really and working with the industry to move this out and move interoperability forward. As we talk about kind of, where is the industry going? What are some of the key initiatives that are actually driving not only interoperability, but certainly healthcare as an industry and an ecosystem, social determinants of health, artificial intelligence, predictive analytics, gene therapy that we're seeing, IPOs and venture capital funding is also in a lot of these initiatives occurring. Interoperability is really at a key of all these as we start looking at not only 2020, but in the future. And you're going to see a slide that I'm going to talk about 2022 and where we're going, and interoperability is front and center there as well. Telehealth, which is really taken on a whole different perspective with COVID-19, precision medicine, and healthcare comparison, shopping, but certainly on the consumer side. And we've seen more and more of that, which is occurring in the industry. Deloitte and PwC, basically, as they were looking at 21, 22 and predictions, what you're seeing on the left-hand side is kind of the medical cost trend that PwC has been mapping out. And you can see how that's been going since 2007. And really driving down from 11.9 in 2007 to right now in 2020, we're probably at about 6%. And you can see there's a high scenario of 10 and a low of 4, but I think they're thinking it's about 6. So the tracking is in a lot of ways here has been in the right direction as we've been trying to manage costs, and interoperability as we look to move that forward is going to be a key player. So those are, at least from a cost perspective. And then you look at some of the predictions that Deloitte has made on, the quantified self is alive and well from the genome side of this, the genetics, the culture in healthcare being transformed by digital technologies, life sciences, data being the key driver in all of this, the whole aspect about precision therapies, and then the new entrants as far as disrupting healthcare, as far as how some of this is continuing to be blurred over time as new entrants are in the market. And this last slide, basically going beyond 2020, talks about some of the political and policy aspects that are shifting, I think, as we're all looking at this. Whether or not it's, the regulatory process itself and the uncertainty around that, the replacement of and modification of current policy with an election coming up. We don't know how that is going to play out. Block grants, association health plans, and other policy shifts. And then current focus is around kind of provider directories, surprise billing, and obviously what we've been doing and focusing on as an industry to deal with COVID-19 and our pandemic response. So all of these are, I think, key drivers, and kind of hopefully puts in perspective a vision for at least where we are and what we're seeing going on. With that, I'm going to turn this over to John Rancourt and Chris Muir from an ONC, and it's all yours, gentlemen.
All right, well, thank you, Lee. Appreciate being invited to participate in this event. My colleague, John Rancourt, and I were asked to address the progress the industry has made in advancing interoperability and some of the relevant ONC projects to move the industry forward. As was indicated by Lee, there's a lot of things going on at ONC. We couldn't possibly address everything, but we're hopefully going to be able to address the most salient things that are taking place right now. So if we can, we got the disclaimer slide up. This is the federal government's requisite and customary slide, just saying that we don't endorse any particular service, product, or program that is presented in today's event. If we can go to the next slide. So to give you some perspective on progress that we've made to date, when I first started at ONC about 13 years ago, EHR adoption was under 10%. That's just providers having electronic health records or electronic medical records within their practices or within the hospital. Today, there's 97% of the hospitals and 86% of the office-based providers have EHRs. So tremendous progress is being made in the adoption side of the equation. But we are working diligently on interoperability as well. For the past several years, we've used the concepts of send, receive, find, and integrate as measures for interoperability. So in that construct, I'm going to talk a little bit about the progress we've made with hospitals. In working with the American Hospital Association on their survey, we learned that in 2018, 89% of US non-federal acute care hospitals were able to send a patient summary of care record outside their health system. 78% were able to receive a summary of care record from outside of their health system. 65% were able to find a patient health health records outside of their system through a query. And 62% were able to integrate that information into their electronic health record. When you look across all those four domains, less than half, only 46% are able to do each one of those things. And so obviously we still have some work to do. John and I are going to tell you about just some of the ways in which we're advancing in these different areas. Near the end, let's go to the next. Well, no, we can leave it here. That's right. It doesn't matter. Near the end of the Obama administration, Congress passed the 21st Century Cures Act that's already been referenced. And since then, implementing cures has been ONC's policy imperative. That's what's given us the direction that we've been following since that time. I personally think that the cures was great because it both recognized some of the challenges that we currently have today, but also recognize some things that we need to do in the future to advance interoperability. Among other things, 21st Century Cures is having ONC do two things that we're going to specifically address in the next several minutes. First, Congress took a look around and they noticed that there were numerous private networks and state and local HIEs and some national networks that were operating, you might say, in stovepipes. They're not able to share data between those networks. And so they asked us to do certain things about that. ONC established or developed the Trust Exchange Framework and Common Agreement Project, TEFCA, you heard referenced earlier, which John Rancourt will address in a few minutes. Another thing Congress did was encourage the adoption of standards-based APIs. They saw how the health community has fallen behind many other industries in leveraging the internet and techniques used in the internet to push interoperability forward. And so That's what I'm going to talk about in the next slides. So if we go to the next slide, please. So standards-based APIs have the potential to really get consumers and patients engaged, also to really support the provider community and advance other of our stakeholders as well. When you think of the current internet commerce sites, whether it's the travel industry, the shopping communities like Amazon, or social media industry, you can quickly see the power of APIs. The functionality found in Amazon, just as an example, is based on APIs, and it provides very robust services to its customers. There are inventory APIs, which tells customers, what's available, and even at times tells which products which products have just a few left. The APIs, connect Amazon sellers to the customers. So it's not just the products Amazon sells, but other sellers as well. And it lets you know about their inventories and their pricing and things. Of course, there's the APIs for video streaming, music streaming, just other things. So it's a collection of applications that are connected to a series of APIs. And you can make one transaction from a consumer perspective, but it connects a lot of different players underneath the covers. And so that's the direction that we would like to head with healthcare. As you can tell, the healthcare market has a long way to go. And as you know, ONC has a program to certify health IT products and services. And as ONC includes standard API requirements into the certification program, we will begin to encourage EHR software developers along with third-party developers to innovate and create very robust services that will hopefully catch the imagination and the excitement of consumers and providers and other stakeholders. Recently in the certification program, we have new certification requirements that supports two types of API-enabled services. Services which a single patient's record is the focus of the API, but also services for which multiple patients' data is the focus. It leverages the HL7 FHIR version 4 standard, the FHIR US Core Implementation Guide, the FHIR Bulk Data Implementation Guide. I'm just going to list a couple standards here, just in case, for those who are interested in this stuff. The Smart Application Launch Framework Implementation Guide for Security. And also, last but not least, well, I probably am not listing them all, but the last one I'm going to mention here as part of the certification is the United States Core Data for Interoperability, or the USCDI. The USCDI is a standard set of health data, classes, and constituent data elements that sets the floor for the data that is to be shared in certified products. The first version of the United States Core Data for Interoperability was adopted as a standard in the latest ONC Cures Act final rule. And also the use of the USCDI is required as part of as part of the requirements for other certification requirements that used to point at the the common clinical data set. And so the USCDI replaces that concept of the common clinical data set. And the USCDI really sets the foundation for a broader sharing of electronic health data to support patient care. We have a plan to continually update the USCDI, so to continually lift the floor. As a matter of fact, we just closed this year's public call for submittals from the public for data classes and data elements to be included in the USCDI version 2. We will be publishing a version of that sometime after the first of the year, and again, engaging with the public on advancing the USCDI for the 2021 year. I just want to mention a couple of other things and what we're doing that's somewhat related. ONC has the Interoperability Standards Advisory, the ISA, which we curate standards and implementation specifications to address specific interoperability needs. We're in the midst of taking public comments on those. Public comments close on Monday, November 9th. And so we, ask for everyone's participation in reading through that and recommending any standards or implementation guides that we have not currently listed, including new use cases that we don't necessarily cover today. We're also currently taking public comments on the standards version advancement process, which enables vendors to use newer versions of standards in the certification program without waiting for ONC to go through the whole round of rulemaking before upgrading to the newer standards. And then finally, on another front, we are working with IHE, which is a group that develops implementation specifications to advance interoperability, to update their current FHIR profiles to the current FHIR version 4 standard, but also look at other profiles that could be developed or adopted to advance the FHIR API environment. And then just really quickly, I'm not sure how much time I have left, but I'm sure I'm getting close to the end here. I just wanted to touch on the FHIR at Scale Task Force. Oh, I'm sorry, did I not ask you to advance slides? I apologize. Can we skip ahead a little bit? I'm sorry, this is the US core data. Here we go, fast. This is the one I want. I wanted to just take a few minutes to talk about the FHIR at Scale Task Force. The FAST project, which we call it, is a multi-stakeholder group convened by ONC that addresses how to get FHIR APIs to meet healthcare stakeholder needs at scale, nationwide scale. Go to the next slide, please. This gives the project structure. There is a executive steering committee that really sets the overall direction of the project. We have 7 Tiger teams that are addressing various groups of challenges that need to be addressed to get FHIR to be able to scale. And then we have a coordinating committee, which makes sure that the solutions that each of the Tiger teams are coming up with are consistent and move the solutions in a common, non-conflicting direction. So if you go to the next slide, this talks a little bit about the process. I think the important part is that the Tiger teams are going through a specific process in which, after they develop the proposed infrastructure solutions, they engage with other stakeholders as well. One of those stakeholder groups are, well, not stakeholder groups, but a technique is we had a series of technical learning community webinars where we asked stakeholders to participate in these webinars and give us feedback on the proposed solutions. And then after we received their feedback, we refined the recommended solutions, and then we had panels of SMEs that also gave us feedback. So what is taking place now are the Tiger teams are now refining their proposed solutions based on the SME feedback. And by the end of this calendar year, they will publish their plans to advance their solutions forward. And it'll include things like identifying pilot implementations and submitting implementation guides to HL7 work groups, for implementation guides to be developed. And then I'll just go to my last slide. Just to give you a summary of the proposed FAST solutions. So some of the solutions include a US-wide solution for FHIR endpoint discovery. Another one is consistent methodology for supporting multiple versions of FHIR across the ecosystem. Another is an approach and requirements for FHIR RESTful exchange intermediaries. Also standards-based approaches for individual identity management, and standards-based solutions for intermediary exchange, including reliable routing with metadata, a scalable FHIR testing and certification platform to get consistency across the products and services, and scalable security solutions for nationwide deployment. And so with that, I will turn the rest of our time over to John Rancourt, and he will talk about some other things that we're doing at ONC.
Thanks, Chris, and Lee and ENAC Coral for having us here and our work together. I'm going to talk today about the Trusted Exchange Framework and Common Agreement. And let's move to the next slide. So as Chris mentioned, there's a history that led up to the 21st Century Cures Act of us as a nation moving from not having wide-scale adoption to having wide-scale adoption, but having challenges associated with interoperability. And that was the context that led to Congress's passing by a wide bipartisan margin the 21st Century Cures Act. And Section 4003 is the TEFCA section, as we call it, where they have this provision that lays out that ONC shall convene public and private stakeholders to develop a trust exchange framework for trust policies and practices for a common agreement for exchange between health information networks. So this is the foundation behind the work that we've been engaged in to advance this goal of connecting different networks to one another. That is needed because of this problem that those networks are, as Chris was mentioning, in many cases stovepiped from one another, and they're not talking to each other for the benefit of patients, for the benefit of our healthcare system, for the benefit of value-based transformation. All of these are reasons that Congress said, let's fix it, and put together the 21st Century Cures Act, which included many components of it, and the one we're going to focus on is TEFCA. So next slide, please. And what do we mean when we talk about a trusted exchange framework? Well, really that is a set of common principles that are designed to facilitate trust among health information networks. We say this trusted exchange framework is going to be foundational, but not binding. And that means that these are the principles similar to what Lee was laying out in the beginning of the presentation about things that ONC is considering as principles behind its strategic work. That includes things like standardization, all of the stuff that Chris's team works on and others at ONC, transparency, cooperation and non-discrimination, privacy and security, access, and also trying to achieve population-wide data so we can have those goals that we need to meet to improve our response to crises and support so many different things. Next slide. And so that Trusted Exchange Framework is part of the work. The other part is the Common Agreement. And this is and will be a legal document that will provide the governance necessary to scale a functioning system of connected health information networks. And really, let me break down what that means and what the different parts are. Most folks on this webinar are probably familiar with data use agreements, trust agreements that allow for sharing between different entities. Not everybody may be as familiar, though, with the challenges associated with trying to bridge the divide between different data sharing agreements. And that's because there's a different set of baselines often in these agreements, whether they be privacy baselines or security baselines, where you may have one set of agreements setting a level of identity assurance at a particular level, and the other ones maybe a little bit less than that. And because of that disparate nature, you don't have connectivity. You can't have the interoperability between those folks. That same thing can happen associated with the technical framework associated with how those folks connect. Or it may be just simply a matter of the difference in governance approaches that those two data sharing agreements take, and the decision making associated with it is so different that you can't have that bridging between those two contracts. And so that's the reason that we've structured the Common Agreement the way that we have. We began with that blue box there of what we call the minimum required terms and conditions. these are the areas of variation that exist among trust frameworks right now, where we need a common baseline set by ONC. ONC is the developer of those components of the common agreement. And then what we've done is we've turned to the industry to say, how can we do this best? We put out a cooperative agreement where we entered a relationship with the Sequoia Project to act as the recognized coordinating entity and to draft this common agreement, building in all of those additional required terms and conditions, that gray box there, around what's needed to make a trust agreement work. This incorporates the minimum required terms and conditions that we have, and also connects to that bottom part, that QHIN technical framework. I'll explain what a QHIN is in a minute, but the technical framework are those technical considerations that connect into the policy, are incorporated by reference into the common agreement and allow for data sharing to occur. Next slide, please. And so I want to talk a bit about what our goals are for these, for the common agreement. And that really starts with providing a single on-ramp to nationwide connectivity. What we've seen and what you all have experienced is that entities must connect again and again and again in order to either receive or send the information that they need in order to provide adequate patient care. Everyone's been in this scenario where particular data was not available when it needed to be for their own care or someone they know. And so that's why we've set this as the initial goal. And that second goal of seeing that electronic health information follows you where and when it's needed, that's really because TEFCA is all about patients. I'll tell a brief story. My daughter was born about 2 years ago, and this was in a hospital down the street where when we were leaving, the nurse came up to me and handed me this yellow folder and said, "Dad, this is very important. You need to carry this yellow folder to the primary care appointment tomorrow." And I'm just standing there like, this is, the most joyous moment of my life, and smack in my face is, professionally not achieving the goals that we've set out to achieve, that interoperability isn't occurring. And then, going to that doctor and of course them giving them the folder because I'm responsible and remembered it, but thinking to myself, why is it that they could not have queried for those records before I arrived, even though literally it's down the street, it's just two different healthcare systems. And so so that's part, why we're trying to do what we're trying to do. The third goal there of support nationwide scalability. We do not think that a single network that's going to achieve everything is possible or is part of our plan. What we do think, however, is that you can have a network of networks approach that does scale and can achieve the goals nationwide of what we're trying to achieve with interoperability. Next slide, please. Okay, so how does this work? And I'm going to walk you through that here so that you can get a good understanding of the basics, and then we're going to, after that, talk about what comes next and what's going on right now with the common agreement. So it all starts at the top where again we have the Office of the National Coordinator and the recognized coordinating entity. Those two exchange lines indicate that there's sharing here between the two of us, where we've established a cooperative agreement to execute on the common agreement, where the RCE is developing, updating, implementing, and maintaining the common agreement through and in cooperation with us as ONC, connected back again to that authority from Cures. And the RCE then is this umbrella organization overseeing the work of the qualified health information networks. Those are the backbone of how we anticipate TEFCA to work, in that these are the entities that have the capabilities to connect other entities that we call participants at scale nationwide and have the means to do so. They all connect with one another to be able to facilitate both queries, message delivery, and so on. Oh, I forgot, this is a build slide. Lee, you're gonna chide me about that afterwards, I'm sure. So these are the labels that help explain that. And the last one at the bottom is what do those QHINs represent? They represent a variety of different participants that all would then connect their own folks together. Those participants, that might be a health information exchange. That might be a group of payers. That might be some other diverse type of data sharing arrangement that includes a mix of payers, providers, or potentially even others. App developers can be connected into the Trusted Exchange framework and pull down data for patients, provided they meet all of those required aspects of the common agreement. So it's really this, again, the goal that we're trying to achieve of having a single on-ramp to that nationwide connectivity. Next slide, please. And so as we wrap up, I want to talk about where we are and what comes next. As I mentioned, the recognized coordinating entity has been hard at work at developing the common agreements. One of the things that what they've been doing is having numerous public engagement opportunities to try and get feedback so that we can get this right. We really need to get it right for all stakeholders involved, for providers, networks, payers, patients, others, so that we can achieve those shared goals that we all have around interoperability. And the Sequoia project's been having public sessions. The Sequoia project, as the recognized coordinating entity, has also pulled together a work group of potential QHINs to work through policies that would be built into what that common agreement would be. We're working with the RCE right now on that common agreement, and the next step is that we would release a draft of that for public comment. So my ask at the end of our presentation here is to please be involved, share your ideas, either through the RCE. You can contact us at ONC. We're working every day with the RCE. I'm going to share a couple links for more information that I'll chat up and I'll put in the chat, but then there's also a couple ways that you can stay up to date on what's happening next. The RCE has a email list that you can add yourself to, and we at ONC do as well. So with that, I am going to pass it over to our next presenter. So looking forward to questions. Thanks so much.
Great. Thank you, John. And John, I just wanted to say as well that from the standpoint of transparency, I would tell you that the Sequoia project, as far as the RCE and ONC, have been extremely transparent in the entire process and really being very open in inviting the industry to participate. So it's been a really very, very good process. So kudos to not only ONC, but to Sequoia as the RCE for that transparency and openness.
Thank you, Lee.
So with that, we're going to turn this over to Ryan Howells. And so hopefully, Stephanie, you can give Ryan, and you've given Ryan control. So Ryan, we'll turn it over to you.
Great, Lee. Thanks for the opportunity. You see my screen okay? Yep, okay, great. Thank you. Appreciate the opportunity to do this. My presentation is going to be about how we can avoid getting yellow folders in the future. That is my presentation. Ryan Howells, I'm as we mentioned, a principal at Levitt Partners. What we do is we try to organize the industry in trying to solve really difficult issues in healthcare, and we run these alliances as public-private partnerships to make that happen at scale. Very action-oriented alliances to try to make this happen. I'm going to tell you some work we're doing in one of our alliances called the Caring Alliance, which is hopefully going to get more data to the individual consumer. One of the questions we get asked all the time, and I'm sure ONC gets this asked question all the time, is why aren't we making more progress? Why isn't it faster? And the answer to that question is it's running about as fast as we can possibly make it run. It is a big, complicated industry. There's been a lot of work that's been going on for a significant amount of time. If you just look at, Chris mentioned this at the outset, it was only 11 years ago that EHR saturation was at 16%. And it wasn't until 3 years ago that we had 85% saturation. We've just had this thing called the iPhone that got released 13 years ago, but has now become part of our right hand. And so that's become significant in terms of how we use data and how we use apps, and what the expectations of consumers are in terms of how this works in your healthcare life. And then we had this thing in 2015 and 2016 called Cures that we had just mentioned, both in terms of the certification criteria in 2015 and then Cures in 2016. It takes time to write those regulations. As ONC knows, it takes time for the industry to adopt them. But I think what's important in this is that we are working together. And I will say, I have never in the 25 years I've been working in the industry seen the industry more coordinated than we have right now. We have, both on the public and private side, huge momentum in what this looks like. And there is widespread adoption and belief that interoperability is not only foundational to what we need to do, but absolutely essential. And so I recognize we have an election coming up, but certainly speaking personally, I would not expect any change in this, primarily because healthcare technology and where we're going as a country, primarily because healthcare technology is a nonpartisan issue. Every administration has built on the great work of previous administrations, and certainly we would expect that to continue. So what are we doing in the Caring Alliance? Well, we have a vision to really find ways to rapidly advance that ability for consumers and their caregivers to easily get, use, and share their digital health information when, where, and how they want to achieve their goals. We were started about 4.5 years ago. We have about 70 organizations and really over 500 people that are involved in this effort. And it's been a great partnership. Large companies like Google, Apple, and Microsoft are involved, including small startups, literally applications that were started in their garage with like 3 people that I could tell you stories about if we had some time, to these multi-billion-dollar multinational companies, and individual patients and caregivers and consumers and individuals who care deeply about the future of healthcare, and everyone in between. We view this as a very much a coordinated effort that is an idea meritocracy. The best ideas win, and the best ideas have to do with how do we get more data with less friction to the individual themselves. So as we think about the future of healthcare data, we have always focused on what I lovingly like to call the HIPAA box. It is the box in which data has been exchanged for 20+ years. We know business associate agreements, we know how that all works, but it's always been business to business exchange related. There has been, unfortunately, a missing component to that. And I will also say there's a whole set of data use agreements that are incorporated in that. There's silos that was mentioned earlier that related to this. 21st Century Cures and the ONC and CMS rules have tried to break down those silos as much as possible and now made information sharing mandatory and not optional, which has been a great move forward, widely applauded by a great majority of the industry and how that has been done. But there's been one person, an individual that's been missing from that, which is the individual consumer. And if an individual consumer wants access to their data, historically, they've had to go to, especially those with chronic conditions, the basement of a hospital and try to find that information. But through the use of EHR technologies, they've gotten portal-related access, they've gotten access to their electronic information digitally, which has been a great first step. And now we're trying to figure out ways where they can start to get access to their data across systems, especially, again, those with chronic conditions. We had one patient advocate who spoke to us recently who was 21 years old and had a chronic condition and had 21 patient portals. I don't expect anybody to memorize their usernames and passwords for 21 patient portals. So if we can make it work for her, we can make it work for everybody. And that is the goal, is how do we aggregate all of the clinical and claims information from any payer provider you've had in the last 10 years to an app of your choice in a secure and consent-driven way is really the objective. What we first started with is we said, we're moving regulatory environments. We're moving from the HIPAA regulated space into the FTC regulated space. And when we do that, we have to have new ways in which that space is actually operating. And the way that the Federal Trade Commission works is that if you are an organization that is in the Federal Trade Commission space, if your terms and conditions of your app says you will do something with that data, as long as you do something with that data, then the FTC says that's great. You've done according to your terms and conditions or your privacy policy. Well, what if an app does nefarious things with the data? That is absolutely unacceptable in healthcare. What the FTC also says is if the industry comes together and agrees on a single common code of conduct for how that data should be handled, used, and managed going forward, then they can be able to enforce that at the FTC. And certainly the private sector could enforce that as well. So that's where we started. We started in the Cairn Alliance to develop that industry acceptable code of conduct for how that data should be shared. And that becomes the foundation by which all of these apps now are handling that data in the FTC regulated space. In addition to that, we're developing questionnaires for how the individual third-party apps are answering how they handle that information. So wherever a consumer goes to select their app, they have a common experience for filtering the apps of their choice. And then we're also working with ENAC and other organizations on the validation step. How do we actually certify that the apps have done what they said that they would do? All of this has to be voluntary according to the current regulations that are in place, but all of them actually are being followed, especially by the app community, who don't number in large numbers. Many are scared that there's 500,000 apps that are going to knock on your door on January 1st, and that actually is not the case. There's only about 60 that are actually connected to a FHIR API in production. And so we know that this group is small. We've spoken to all of them, and we know that they want to do the right thing. Now, we need to protect for those that don't want to do the right thing. That's the importance of the code of conduct and the certification framework as well, so that we can ensure that these apps are not only doing what they said that they would do, but also are making sure they are enhancing the privacy, security, and consent bar in terms of how they handle individual data. These are some of the principles in the code of conduct. We have built it all around informed, proactive choice and intentional decisions for how that individual should actually handle that app, or I'm sorry, how that app should handle the data on behalf of the individual, I should say. There's no default data sharing in this world that we are going to move through. We also have, as we mentioned, structured kind of consistent reportable responses for how the apps are actually handling the data. And then we're always specifying the purpose for how the data is being used. And we're also, we could talk about how we're binding downstream third-party actors at the same level that we're holding these apps accountable to as well. But these are all principles that we hope will actually raise the bar, again, in terms of privacy, security, and consent, even beyond what HIPAA requires today. And that really has been our goal from the outset. Many have actually adopted the Cairn Code of Conduct. For a list of those applications that have attested to the Cairn Code, you can log in maybe after our webinar, but myhealthapplication.com, and you can see a list of those apps that have actually attested to the code, and some of them are actually available for download that you can aggregate your data today. CMS has actually adopted many of the principles that we included in the code in their Blue Button, their production access checklist. And the VHA actually uses the code and is a supporter of the code, as indicated in their website, in how those apps are actually connecting with their gateway, their Lighthouse API gateway on behalf of veterans around the country. We've also worked with Care Equality to find ways, as we mentioned as part of Sequoia and the recognizing coordinating entity, to find ways where all of this can really get folded into the work that they are doing too. At some point, we're having conversations about how that could best work. So the CMS rule talks about patient access API that we'll talk about here in a second. There's a lot of things in the CMS rule itself, but just know that both payers and providers are building API gateways as we speak, so that this FHIR API information can be exchanged between both payers and providers. We'll talk a little bit about what we're doing on the payer API set in a second. This is a note about USCDI that we had talked about earlier that Chris had mentioned already. I think the key point here is that many more data elements are being provided at scale in the United States through the use of these APIs, not only this year, but also in 2022 and on a go forward basis. And so we're excited to see that, and we're excited to see all of the different apps that are actually being able to use this on behalf of the patient. So what is industry doing to respond to this? And I wanted to amalgamate the responses that we're hearing from industry on how they are structuring and organizing their individual architectures to support this new world. It really falls into 4 buckets. First of all, they've realized that digital identity is super important. I think we've realized that for a while, but we've called it something different. We've called it patient matching. And patient matching meant the data comes in from all kinds of different endpoints, and that information is often incorrect. And then we have identity, we have these patient matching solutions to try to match this data across the system. But we never have a source solution or a source system by which that data is being matched to. And that data, that person, that source is actually the patient. So what if we flip that on its head? And what if we said the patient is the one who actually develops their own digital identity that has been identity proofed, similar to how you would do in a driver's license type situation. And you would actually go in a digital world and find ways where you can create your own identity proof digital credential. That's why many folks that we're hearing in the industry are separating their identity and access management services from their back-end system. That's become absolutely important to do that, because not only in B2C exchange, but also B2B exchange, this becomes critical. Secondarily, they're obviously building API gateways to exchange all of this information across the board. Third, they are looking for ways where they can develop an application registration utility, where either a B2B or a B2C app could come in and register, receive the OAuth client secret, and then be able to access the data that they're entitled to. That becomes super important, because otherwise you're not going to be able to get these community of problem solvers together in a holistic way to solve the myriad of healthcare use cases that we have to solve for. And so let's ensure that we do that in a meaningful way. And then finally, we think that consent-based sharing, individuals consenting to how they want their data to be shared and with whom, is going to become ubiquitous in healthcare. We think it's going to become universal, because right now, no one knows they have digital access to their data on their app. I say no one. There's probably a less than a percentage population that do, and most of them are on this call. But there are others that actually are learning that they have that access. And when so doing, they want the same flexibility that they have today in the consumer world, where they're consenting to where their data gets shared. Now, the good news is we're ahead of the consumer world in the sense that we're putting together these frameworks in place, and they have not. That we've learned from their mistakes, I think, a lot of the cases, but we're also trying to find ways where we can make it even better and try to lock down that data, because it is healthcare and specific to an individual. There's a lot of great work going on, and a lot of different what they call HL7 Fire Accelerator programs. These are groups of organizations who have come together within HL7 to be able to develop fire implementation guides, so that we can, and they are implementers who are going to accelerate the use of fire in the implementer community. DaVinci is one of those, Karen is one of those, Gravity, and a whole bunch of other ones. As it relates to the CMS rule, you know, there are 3 different aspects of the patient access API: DaVinci Formulary, the DaVinci Payer Data Exchange, and the Karen IG for Blue Button, that are core to actually making patient access API work at scale. There's also the Karen Real-Time Pharmacy Benefit Check API that was published by HL7 earlier this year, which allows for an individual who has already selected a plan to be able to access their formulary and benefit information, out-of-pocket costs, therapeutic alternatives, and cash price. We're working with a whole bunch of PBMs right now to make that a reality, hopefully beginning next year in production, so that you can take an app of your choice, and now after that, after you have been prescribed that medication, know where to go to actually get the best medication for you in terms of you know, working with your doctor in terms of how it affects you individually, and also potentially the lowest out-of-pocket cost based on, you know, which pharmacy dispenses that drug for you, or whether or not you should pay cash or use your benefits to make that happen. So all of that information should become readily available here within the next couple of years. A lot of links here that we won't go through. One in particular that we want to call your attention to is the CMS questions and answers. We have linked on the HL7 Confluence page a whole number of questions and answers if you're a payer from CMS, where they've clarified a lot of questions that I'm sure you probably have in terms of what does it mean to maintain the data, whether or not dental and vision claims are included. There's all kinds of different things that are out there that CMS has been able to clarify for us. You can go there or obviously email them directly for some of that information. We have a Connect-a-thon coming up as well on November 18th and 19th. If you want to reach out to us to learn more, feel free. We talked about real-time benefit check. I just want to mention here that CMS has said that this is an important thing for them. They call it a real-time benefit tool, and from a B2B perspective, that's going to be in place by January 2021. They've also called it a beneficiary real-time benefit tool. That was left out of a proposed rule earlier this year, but it was referenced in the final rule that it's under requirements to be addressed later this year. So you may potentially see from CMS that there may be some requirements associated with providing this type of functionality to individual consumers. I mentioned about what the real-time benefit check actually does. This gives you a little bit more information that it, in terms of the fact that it does provide that type of functionality as mentioned earlier, and it does, and also what it doesn't provide. And we've got a link there at the bottom so that you'll have that. Let's talk about a little bit about identity as we kind of finish up here, and what is digital identity and kind of where we go as an industry on this topic of identity. The TEFCA that was mentioned earlier by John and Chris has mentioned that for individuals that are on essentially the TEFCA network, that they will be identity proof to what's called an Identity Assurance Level 2 and authenticate to an Authenticator Assurance Level 2, which is part of the NIST guidelines, 863-3, for those who want to get into the gory details. This is important because it is the national standard for how identity proofing and authentication should take place for the country. We are super supportive of this and made reference to it in the comments that we had made to ONC back in 2017 when the NIST standards came out. And this is important because it actually establishes an industry-wide standard for how identity should take place. But the industry needs to still rally around a framework for how that's going to happen. We organized a group of folks along with our partners at CMS and ONC back in June of last year, where we started to think about these topics more holistically. You notice that patient matching was only one of the topics we talked about. We also talked about identity. We talked about authentication. We talked about trust and federation. We talked about what consent means, and then we talked about matching. And the groups rallied around these core principles, the NIST standards themselves, the idea that we need multi-factor authentication. And there is we'll talk about FIDO here in a second, but also how do we do trust and federation at scale? How do we do consent at scale? And how does that eliminate, not necessarily eliminate, but how does that reduce our need for matching across the system? Whenever I say digital identity, the first thing folks actually say is, well, we need a national patient identifier. Well, that's actually not the case in terms of, that's not necessarily our solution. A national patient identifier, while it would be great if we had one, is, although I'll quote Don Rucker in this because he did say this publicly, we have one, it's called a social security number, and that causes everyone to kind of cringe a little bit. But what a national patient identifier would do is actually would identify folks and would act as another trusted identifier for an individual that would come from a trusted source if we ever get one, and there's some policy hurdles to making that happen. What a digital identity is something different. It uses those trusted identifiers, many of them, including maybe your driver's license information, your passport information, potentially a national patient identifier, potentially demographic information that has come from a trusted source. All of those things you use together to then actually create a digital identity. Mobile driver's license is an example of that. It's in 14 states right now, either in production or in test. And we've worked with the organization that's developing the mobile driver's license standards for how that could be integrated into healthcare, and you should see that coming in the next few years. It's kind of an example of how we're building a trusted federated ecosystem. We don't have a ton of time to get into this, but just so you know, we see this as foundational between identity providers and relying parties, where in order to establish that trust, they need to get certified by one of these trust framework organizations. Many of you on the phone know about Direct Trust as a certifier that's out there today. There's another group called Kintera, which is an international certification organization, Safe Identity, and DIAC, which is actually in Canada, who actually certify these identity providers. And when you do that, you can pull them all together under a contractual framework called the Digital Federated Trust Agreement that potentially may even eventually at some point in the future be part of a common agreement where these trust framework organizations then can trust each other and have equivalency across the board for how identity works at scale. What does that all mean in real life language? It means that I can go get a digital identity proof credential somewhere from one of these trusted providers, and I can use it across any system that I want, any provider, any payer in the country, and it can be trusted. And in fact, there's an opportunity to actually eliminate the need as well for usernames and passwords using what's called the FIDO standard, FIDO2 CTAP or WebAuthn, which is a W3C standard, which actually completely eliminates the need for usernames and passwords and has been adopted by Android, iOS, and Microsoft. So you'll see actually usernames and passwords being eliminated off the internet within the next kind of 12 months or so as that gets widely adopted. And that will also filter into healthcare in a meaningful way. So here's kind of a step-by-step plan for what you can do as an organization to move to this new reality. Certainly separate those IAM services from your backend is the first one. Strengthen your authentication protocols by learning about what FIDO2 is doing. It's accepting these identity proof credentials. There's all kinds of resources out there. In fact, the driver's license service has an ability to go and retrieve an API from all 50 states right now, so you can validate whether someone's driver's license is valid or not. There's all kinds of really great things that are occurring, and then supporting these ways for establishing a federated kind of identity proof credential across these systems. So final few slides, and then we'll open it up for questions here, but or turn it over back over to Lee, I should say, is we see this as a lot of things that are going from a disruption perspective, what innovators are doing. Transparency is now the name of the game. We see this actually scaling across the healthcare continuum. How do you make the data useful? How do you engage new applications? If you're a digital health company, just because you have the data doesn't matter as much anymore. Now it becomes, what are you going to do with the data? Do you have the consumer's consent to use that data in that way? And then what value are you going to add to the healthcare ecosystem because you exist? Those transparency models become even more important going forward. You're going to also see pharmaceutical information organizations really get into what's called real world evidence and real world data at scale now because they have more access to that information, which means it will decrease the time to market and hopefully decrease the prices as well in the supply chain. And finding ways where, how are we going to start to address the privacy issues that will emerge when we have this merging of PHI data as well as consumer data? What does this actually start to look like at scale? And it'll be interesting to see how that follows suit. So I think this is the final slide, but just follow patterns. At HIMSS, I think it was 2 years ago, I don't know, it was COVID time, so I can't remember how long it was ago, but you had Anish Chopra, you had Karen DeSalvo, you had Mike Levitt, you had Seema Verma on stage, and they were all filling in each other's sentences from across multiple different administrations about the importance of interoperability, importance of healthcare technology, and what it can do for the industry. This is nonpartisan and it will definitely continue. We see this as the technology is easy, actually easier, I should say, not totally easy, but the business transformation is hard. If this is only a technology conversation within your organizations, you're behind. You should really start to focus this on a strategic conversation around what are we now going to do now that this technology, now that this information is fully transparent to the individual consumers. How are we going to add more value? And then obviously you can either lead or you can follow. Our hope is that each of you will be leaders as we go through with that. So more information about us, but with that, I will turn it back to you, Lee.
Thank you, Ryan. Appreciate it. And I guess, Stephanie, can you, Ryan, do you have the rest of the slide deck on with you there? Or I guess I can go back here to showing my screen. And I've got to get my slide deck up, and you're seeing all of my family here. Isn't that great? All right. So why is this not coming up? Okay. That's what happens when you would try to do everything again to get back to where you were. So, hopefully everybody's seeing my slides now.
Got him.
Okay, great. So let me take just a couple of minutes to go through kind of what, and this is more informational. You know, you've heard from ONC, Ryan, as far as what everybody is doing regarding interoperability. So let me just tell you that I'm going to go through this pretty quickly. ENAC has developed a couple of programs, again, focused on interoperability. And this first one is all about what is called the Trusted Network Accreditation Program. Again, what we're trying to do here, this really aligns with TEFCA. It also aligns with 21st Century Cures. It does not mean that an organization going through this is going to be accepted as a qualified health information network or as a participant by the RCE as John went through. But again, this is all about providing a level of stakeholder trust. And we've partnered with HITRUST to have the privacy and security aspects. This also takes into account technical processes, business, as well as the resource management that organizations have to support. And if organizations are using technologies like blockchain or other types of technologies, this also goes through that as well. So this is basically kind of a very good program for, again, the QHINs as well, those that want to be a QHIN, those that perhaps want to be a participant, to provide that level of stakeholder trust that we think is important. And again, from an alignment with interoperability, what ONC is doing, et cetera. So this is a good one to take a look at, goes to show you at least an example of interoperability accreditation that we're doing. And again, this was based upon a collaboration with a number of healthcare organizations in the industry as we developed that. Then we developed this other program that we're in the process of launching, which is called the Trusted Dynamic Registration and Authentication Accreditation Program. This is all about really going through and helping application developers, demonstrating their ability to use trusted digital certificates and validating endpoint identity, registration, authentication between various transactions and the endpoints using the UDAP protocol. So this is another example, and we're just in the process of putting this in beta. We've got 4 organizations that are going through this. We have two types of programs here. The basic, which is really kind of going through a minimal validation of the, including the UDAP technical framework, demonstrating really end-to-end API validation, and a comprehensive, which goes through and adds really the privacy and security. So again, this is all about interoperability and really integrating with what's going on as far as the FAST initiative that John was going over, and what we're trying to do as far as, again, raising the bar on stakeholder trust. So these are a couple of examples and informational for you to at least know, hey, there is an organization that's developing some programs here that you can take a look at. There are a number of others, as Ryan talked about, and we've incorporated the Caring Alliance as well, Code of Conduct in this. So let me now go over to Cliff and really the security and privacy risks that he wants to talk about and what Coral is doing. So Cliff, let me turn it over to you.
Thanks, Lee. And I know Lee and I are just too glad to host this event, and so we're just bystanders, and I want to make sure we give John, Chris, and Ryan ample time to answer some questions here. So I'm just going to really shorten my presentation here to a couple of key points. We represent the point of view of really the covered entity or health plans and health providers that are integrating different technologies into their networks. And as a security professional, you know, when you hear about liberating health information, you hear about the scaling up APIs. Your tendency as a security professional is to freak out, red alert, and your natural reaction is to shut down access, and that's really what we're trying to avoid, right? As security professionals, we want to empower and enable the strategic objectives at hand here, and really the strategic objective here is interoperability. We're big on standards, and I think as John mentioned, you know, we've seen 1 million data use agreements over the years, everyone with a different flavor of requirements and security checklists and security assessments, and that's part of the problem, really. You know, every technology company that's trying to come to market, that's trying to figure out how to integrate, is really working with different requirements from a customer perspective, and that complicates the whole equation. And so, you know, one message I want to emphasize here is for our constituents to leverage standards, right? To leverage a common agreement, to leverage what Karen and Code of Conduct is doing, and to leverage what ENAC is doing, rather than duplicating that effort, rather than coming up with proprietary checklists and requirements. Let's leverage these standards and then augment that where necessary. But there's a lot of value out there for us to leverage as it is. I think there was a number of key points I was going to cover off here. You know, they're in the slides, so you can use them for your, you know, they're here for your reference. You know, probably the two key takeaways I'll say from a practitioner standpoint is, you know, make sure there's some diligence around inventorying who and what applications connect into the network and the data flow amongst those applications, and then understand how you disconnect, not only how you connect, but also how you disconnect technologies when you have to, and what that means both to your network, to the patient, and to any other stakeholders involved. And then finally, in this day and age, I think understanding how you respond in the event of an incident. So making sure that you can corral the various technology and stakeholder partners that you have that are integrating. Make sure that you can corral those teams together to collaborate on how you respond to an incident, particularly if it's a broad-scale incident, is really critical, I think, in terms of the success of this type of integration over the long term. So with that, I'm gonna button up my comments here and turn it back over to Lee so we can get to some questions.
Thanks, Cliff. And I just want to emphasize one point. You know, Coral, first of all, we appreciated the fact that we're doing this with Coral as well, and obviously with ONC and Karen. The other thing that Cliff was mentioning that I think is important as a takeaway for you is that Coral is really a third-party assurance entity as well. And so as organizations, in the effort to kind of raise the bar on stakeholder awareness and stakeholder trust, as organizations are looking to mitigate their own risks having to do with cyber attacks, as well as HIPAA, Coral is a very significant player as far as working with those organizations on behalf of them to raise the bar on third-party assurance to mitigate some of that risk for many of their clients and organizations. So it's a very important role that they're playing out there. So with that, let's go into the Q&A portion. Let me first go, Stephanie, let me ask you, are there any questions that from the audience at this point? Stephanie, do you have any questions at this point? All right. let me go into then, while Stephanie is hopefully going to be giving us any questions. Chris, you're there, right?
Yes, I'm here.
Hey, Lee.
Okay. Well, let me ask you a first question here. How does one participate in further developing the US CDI by recommending the addition of data classes and data elements? Do you have any guidance for people there?
Yeah, no, yeah, I appreciate that question. It's something that is kind of near and dear to my heart. My team is responsible for further developing the US CDI. Yeah, so we have a system online. It's called the OnDeck system. And if you go to healthit.gov/ISA, there's a link to the OnDeck system for US CDI. And there, people can go out and propose data classes and data elements to be included. And there's an annual process in which we go through to vet and to advance the proposed data elements and data classes. We will include them in the US CDI as they reach a certain level of maturity in both standards and adoption and some other criteria. And anyway, we really encourage our stakeholders to participate with us in that process. When you go out there, you can see other proposed data elements and data classes, and you can make comments on those to help us, to help provide additional evidence on, where those things are being used and the standards that are supporting them and those kinds of things.
Great.
Hey, Lee.
Thanks, Chris.
Hey,
Yeah.
Lee.
Yeah.
I can see the questions, and I can ask them real quick. There's a couple of questions about TEFCA, and there's questions
great.
about when draft 2 is actually going. When's the next version of TEFCA actually going to come out? When will it be finalized, and when can we expect the QTF to be finalized?
Yeah, I'll take that, and thanks, Ryan. The process has been that the RC's received feedback from this Common Agreement work group, and now we're working together with the RC on the draft of the Common Agreement. And so the next step is to release that for public comment, and I do invite folks to sign up for alerts on when that would happen. That's what I had chatted in the poll. So if folks can sign up for that, they'll keep up to speed on the latest information there.
John, one other quick question for you. Has ONC established that a third-party accreditation program could approve HINs to become QHINs?
Yeah, this is a really good question in that there are different ways that we as and then the RCE could run the network. And this is one of the policy questions that we've gotten feedback on, and we'd be eager to continue to hear from folks on that. So again, please, reach out to the RCE, attend our sessions, et cetera. But this is one of those areas that, when we come out with that common agreement, we'll have more clarity on for folks.
And I saw one for Cliff here, Ryan. I guess if an organization is HITRUST certified, why are individual plans requiring their own questionnaire? What can we do as an industry to simplify this?
It's a great question. I think it points back to some of the comments again that John made around, in a similar vein to the data use agreements, building some conformity and standards around the requirements that we're having of technology vendors that are plugging into networks. And yes, I believe there should be much further widespread adoption of these certifications, whether it's HITRUST or SOC 2 or certainly all the great work that ENAC's doing. I think that goes a long way to simplifying how assurance is communicated and simplifying the responsibility that payers and providers have in trying to confirm that type of information themselves. So I'm a big proponent of leveraging those type of assurance practices.
Okay, great. Thank you. I think we're at close to the bottom of the hour. Do we have any, Ryan, did you see any other questions? I didn't see any here.
Have there been any updates to the privacy and security components of TEFCA? Any updates coming in this space, such as further definition of security labeling, et cetera?
Yeah, I can take that. That's going to be a similar answer, which is, yeah, we're working on what that's going to look like. So stay tuned, sign up for updates, keep giving us feedback. Eager to continue to hear from folks on that.
Yep,
Great.
I think that's late.
Terrific. Thank you. So, and thanks to all the panel, to Ryan Howells, Chris Muir, John Rancourt, Cliff Baker. Great session. Thank you all for your participation. And as I indicated, you'll get a link tomorrow in an email, so you'll be able to get the recording. And it's going to be a top 10. Believe me, it's going to be in the Academy Awards, and we're looking forward to being nominated for that. I appreciate all the panelists again, and Coral for sponsoring with ENAC as well. We appreciate all of your participation, everyone. And listen, have a great rest of the day. Thanks to all of you. Take care.
Thank you, Lee.
Thank you, Lee.
Thank you, Lee. Thanks for hosting.
Thanks, Lee.